Hello, everyone. My name is Marcelo Corassa. I'm a medical oncologist, lead of thoracic oncology unit at BP, Beneficência Portuguesa de São Paulo. And I would like to thank the guys at Brazilian Information Oncology to allow us to have this discussion with the amazing Dr. Aaron Lisberg. Actually, I'm going to let you present yourself. This is better.
Sure. Yeah, so my name is Aaron Lisberg. I'm a thoracic medical oncologist at UCLA. So happy to be here today.
And you just published a JCO paper right now because it just went out like 5 minutes ago.
Yeah, it should be up online. So Jacob just presented the data, the final overall survival analysis from TLO1.
Yeah, we're going to discuss TROPION-Lung01 a little bit here. I think everyone is quite aware about the data. We had this presented at ESMO last year. But right now, I think the first thing that I wanted to ask you right now, how do you feel about the results that were just presented right now about overall survival?
Yeah, so I think that it's important to understand the conception of the trial, and that there were two dual primary endpoints as I presented at ESMO, and that at ESMO we presented that there was a statistically significant improvement in PFS in the overall study population. Certainly, it appeared to be driven primarily by the non-squamous population, and we saw a trend in favor of overall survival in the overall population that again was driven by the non-squamous at ESMO. We see the final overall survival analysis, and we see something similar. That said, we do see that the second of the two dual primary endpoints, overall survival and the intention to treat population, did not meet statistical significance. There was a numerical improvement, although marginal, I would say, in the intention to treat population. But again, in the non-squamous population, we are seeing a greater degree of benefit, which primarily appears to be driven by the AGA patients, which is the patient population that did best from progression-free survival as well. So it's a continuous story. I think that it's important to kind of look at the data packages as a whole. Another important point I think there was to take out of the data that was presented today was that despite, I think, 11 more months of follow-up, the safety summary appears similar, and that, again, appears to favor Dato-DXd over docetaxel. So it's good to see the additional data.
So you mentioned the AGA, the actionable genomic alteration population. Do you think we're ready to move to prime time? This is the drug that we should use for maybe patients that receiving TKIs and targeted therapy. This is good for every patient with AGA, or maybe just the most common ones that were evaluated on trial.
Yeah.
How do you feel about the drug in this particular population?
Yeah, no, it's a good question. I think we have a lot of evidence in the AGA population as a whole that this is an effective drug. The TLO5 study, which was previously presented, was a single-arm study in the AGA population. Again, when we do these studies in the AGA populations, they are primarily, and we should acknowledge they are primarily EGFR, because that is the most common. And so that is where we see the strongest signal, but I think that we are seeing good activity across the AGA spectrum. And when we look at the PFS data, again, the hazard ratio was the best in the AGA patient at 0.38. When we looked at the final overall survival analysis, again, we're going to smaller and smaller subgroups, and certainly the trial wasn't powered to evaluate these questions specifically, but we see a pretty significant improvement in overall survival in that population too. So I think that there's a lot of evidence to support the use of Dato-DXd in that patient population, but I think ultimately we're going to have to see how the process plays out, and I certainly think that this is a potential option for patients like that.
And it's all about patient selection, right? When you were discussing the TLO1, we had squamous patients. If you go into the first line trials, we are just dropping patients with squamous. The Avenger trials started with squamous patients, and now they were not eligible anymore in the final phase. So squamous is not something that we should put on the table, right?
Yeah, when we're looking at TLO1 specifically, certainly I think the data presented at ESMO and followed up here 5 minutes ago supports the idea that the histologic breakdown is a real defined way to see this drug activity, which is similar to many drugs that we use in clinics, such as pemetrexed, where we'll see a real dichotomy. And so it's the non-squamous patients that appear to be driving the benefit we're seeing with Dato-DXd. And I think that that's kind of where we need to focus for now. That said, I would like to also highlight, I know it's not topic of the discussion today, but the QCS presentation yesterday, looking at a novel.
Oh, my next question.
Okay, there we go. So good. So I'll segue into it. I'll take your job too. So I want to highlight that as well, and I think it segues into the discussion you just had. So the QCS presentation, as your audience may be aware, was looking at a novel approach to evaluating TROP2. We know that membrane TROP2 does not predict for response. Dato-DXd, which again was surprising to us. You'd think that the target of these ADCs would predict for response, but that's not what we've seen with Dato-DXd. It's not what we've seen with patritumab TCAN either. However, the presentation yesterday showed that a ratio of the cytoplasmic TROP2 expression compared to the membrane TROP2 expression, with the higher the cytoplasmic ratio to the membrane ratio predicted for a higher likelihood of benefit, specifically in the non-squamous and really in the non-squamous non-AGA patients. So I think taken in totality, this may be a way for us to further refine the therapy. And then to your question about squamous, when we looked at the prevalence of this biomarker positivity, we see a much higher prevalence in the non-squamous, in the AGA population, and in direct contrast to the squamous. So this could be adding, and some of the story we're seeing in terms of histologic breakdown. But I certainly think this is early phase in terms of this exploratory analysis. But I think it's exciting because anytime we can enrich a patient population and have a higher likelihood of providing benefit to our patients down the line, I think that's important.
I think this is the most important thing for us to know. And like we were saying, patient selection, I think this is fundamental. And because Dato-DXd is not as toxic maybe as docetaxel. And I was asking a question to some friends recently, do you feel comfortable giving docetaxel to patients? And every time it's like a consolation prize. That's what we have. Yeah. So the idea here is to determine which patients will benefit the most. And I think this is the main topic of discussion. Many people say, oh, the trial had limited potential. No, I don't think it's limited potential. We just need to find the right patient for the right drug. So I think it summarizes. And I would like to thank you so much for having us here, for having this discussion with you guys. One of the guys who published the trial, I think you and Jacob were co-senior authors. So with you, the co-senior author of the TROPION-Lung01, Aaron Lisberg. Thank you so much. And thank you, Aaron, for being with us.
No problem. Thanks.